In this lecture, we'll talk about dermatitis. And we'll start first by discussing the risk factors for dermatitis. And this is our first question. All the following factors are associated with a higher risk of atopic dermatitis except, and the answer for this question is
A. Actually, higher socioeconomic status, not the low socioeconomic status, is associated with higher risk of atopic dermatitis. Asian and Black Caribbean especially have a higher risk, especially in dry and cold climates. Patients with family history of atopic dermatitis are at higher risk. Individuals who live in their own home are at higher risk, and being the only child in the family is also a higher risk. So having a small family, like the less number of kids we have, the higher the risk of having um, atopic dermatitis. Next question is about the risks and triggering factors, and all of the following are aggravating factors for contact dermatitis except, and the answer for this question is A. Actually, patients with HIV, they have a weak immune system, and they have a weak inflammatory reaction because of the weak immune system. Other risk factors and aggravating factors that you can see also here on this slide. So sexual intercourse and any body contact such as sports increase the exposure to the allergen. Ultraviolet radiation causes phototoxicity and it can also aggravate the symptoms. And Caucasian ethnicity has a higher risk of skin permeability or has higher skin permeability, so they have a higher risk of atopic dermatitis. Other risk factors include females because females are at higher risk of exposure to contact to irritants such as detergent and soaps. Also, cold and dry air and occupational exposure also increase the risk. Occupational exposure are those who work in industry when they are exposed to chemicals and stuff like in the rubber industry and stuff like that. They also have a higher risk of developing atopic dermatitis and contact dermatitis. So here's the next question. Patients who develop contact dermatitis reaction secondary to exposure to latex may develop reaction when they are exposed to all of the following except, and the answer for this question is D. Actually, those who develop allergic reaction when exposed to latex develop cross-sensitivity reaction when they are exposed or when they eat banana, pineapple, apricot, and grapes. Um, Not strawberries. So that's an interesting one. This is a cross sensitivity between food and latex. Also, other food that may cause the same cross sensitivity reaction are kiwi, peaches, cherry, potato, tomatoes, avocado, and chestnuts. Interestingly, also, those who are allergic to poison ivy may develop cross sensitivity reaction when they eat cashews. Now let's look at some medications that may cause skin like eczematous skin eruption. So all of the following medications can cause eczematous skin eruption except, and the answer for this question is leflunomide. So many medications can cause eczematous skin eruption. These drugs include propranolol, nifedipine, gentamicin, carbamazepine, and on the next slide we have another list of medications that can cause similar adverse. So we have here a list of medications. It's just very self-explanatory in terms of anti-infective: sulfapenicillin, nystatin, chloramphenicol, neomycin. All these medications can cause skin eruption. Um, Cardiovascular drugs: calcium blockers, thiazide diuretics, beta blockers, metoprolol, propranolol, timolol, nitroglycerin, minoxidil, quinidine, prokinamide, and some CNS drugs like chlorohydrate, phenothiazine, and antipsychotics. And finally, we have also some aminophylline and sulfonylurea. They may cause skin eruption that looks like dermatitis. So this table is a little bit busy, but basically we are comparing the two conditions we talk about here. The first is atopic dermatitis versus contact dermatitis. So let's start first with the atopic dermatitis, which is the same as eczema. And this is a chronic inflammatory skin reaction to environmental allergen. And that's an important thing. The patient gets exposed to environmental allergen, and because of this exposure to the environmental allergen, there is severity dependent elevation in the immunoglobulin E. So when the condition is mild, the immunoglobulin E mildly elevated. When it's moderate, the immunoglobulin E is moderately elevated. When it's severe, it's severely elevated. And eczema is more common in children, mostly between 1 to 5 years of age. And actually having atopic dermatitis at young age can increase the risk of contact dermatitis later in life. For contact dermatitis, it's also a reaction due to contact with the skin allergen. So here the skin, it is a skin allergen, something that specific allergen to the skin, something like latex, like perfume, lanolin, nickel, cobalt, poison ivy, poison oak. So these are specific skin allergens. Sometimes it's also due to contact with drugs.
such as bacitracin, benzocaine, topical antihistamines, and neomycin. These are skin sensitizers, so they can trigger contact dermatitis. Sometimes the contact dermatitis can develop due to contact with cosmetics, such as aloe, hair dyes, paraphenylamide diamine. Sometimes the patient may develop that due to non-allergic skin irritants, such as solvents, soap, detergent, acids, etc. And it can happen at any age, and the severity will depend on the extent of exposure. So, for how long the exposure is, the quantity of the allergen or the drug or the cosmetic, the frequency of the exposure, is it one time every year, is it every week, and the skin integrity. Is the skin infected? Is the skin burned? Because all of this can affect the severity of the condition. So, for example, if you have someone who works in a restaurant to wash dishes, every day this person is exposed to the detergent. So this person may have a more severe contact dermatitis if he is allergic to this kind of detergent. So that's what we mean by the duration, the quantity, and the frequency. This is different than someone who may use the perfume once and then they find that they have a reaction and they stop using it. So they will get less severe reaction and so on. In terms of clinical presentation and the symptoms, so for atopic dermatitis or the eczema, the patient usually has itch. It can be acute or chronic. That leads to scratching and excoriation of the skin, so scraping the skin, and this leads to scaly skin. When it's acute, the skin may be oozing and vesicular, so the skin will be kind of wet. The site of the lesion in eczema is age dependent. So the face and the scalp are more common for in infants, neck and extremities for children, and the flexural surfaces of the joint, like for example in the hand, is more common in older children and in adults. So the site of the eczema differs according to the age of the patient. But again, um, any age can be affected anywhere, but these are the more common ones. As the problem progresses, the acute problem, it will move from acute to intermittent relapsing. The skin will start to become thicker, the dryness will start to increase, the patient will go through hyperpigmentation of the skin. So these are the progressive nature of the eczema. For the contact dermatitis, the clinical presentation is affected by the location of the contact. So for example, as we said, if someone is working in a restaurant to wash dishes and this person has reaction to the detergent, it will mainly affect the hands. He will not have any lesions anywhere else in the body. Um, For example, here, the chest can indicate allergy to jewelry. Hands can indicate allergy to detergent. Around the neck may indicate allergy to maybe perfume. So the site of the dermatitis can guide us to know exactly what causes this reaction. Faces and eyelid are more sensitive, while the palm and sole and the scalp are more resistant. Acutely, the lesions are red and edematous, then they become vesicular and oozing. Chronically, the lesions are dry and the skin becomes thick and there is hyperpigmentation and the skin starts cracking. Itch is the hallmark in all the stages. So all the patients, acute and chronic, do have itch. And there are some strong irritants that can actually cause ulceration. For example, if the patient is exposed to strong acid or strong alkali. So as you can see, we have some differences in the presentation between atopic dermatitis, where the site depends on the age, and between contact dermatitis, where the site of the dermatitis is affected by the agent or determined by the agent to which the patient has a reaction. What triggers them? So in terms of triggers in atopic dermatitis or eczema, stress, sweating, and the sweating triggering activity like exercise or something like that. Extreme weather conditions such as dry weather, high humidity, temperature, cold or hot, and here both of them can trigger eczema. So that's why we say extreme temperature, too cold or too hot, both of them can trigger it. Skin irritants such as coarse texture clothes, wool, detergents, fabric softener, especially the sheets and liquids, shampoo. All of these agents are skin irritants that may trigger eczema. Also drying agents such as alcohol and astringents, food allergy, and itch. And itch, the problem with the itch, it is self-propagating. So itch makes the patient, once you itch, the patient wants to itch more. So itch causes more itch, and that's what we mean by self-propagating. In terms of contact dermatitis, we have some questions on
the triggers. There are many triggers, and the risk increases in patients with atopic dermatitis. And we mentioned before that atopic dermatitis increase the risk of contact dermatitis. There is also another condition that's called stasis dermatitis. Stasis dermatitis. This is inflammatory skin reaction, usually on the lower extremities due to venous insufficiency. For example, when the patient does not move, when the blood remains for a long time in the veins, this can cause stasis dermatitis. This can happen in pregnant women because they don't walk much and they're like getting heavier. Also, patients with prolonged bed rest, or for example, after the surgery or something like that. Clinical presentation, again, it can be acute or chronic. In the acute phase, it's usually inflammatory. There is erythema, edema, oozing, and lesions with ulcerations and hyperpigmentation. In chronic, the skin starts to become thicker, thickening of the skin, and discoloration of the skin. In terms of management, and here we'll talk about the stasis dermatitis management. This is management only for stasis dermatitis. Atopic dermatitis and contact dermatitis will be discussed in details in the next slides. So in terms of management for stasis dermatitis, there is no specific treatment. We avoid applying topical ointments. Compression stocking and bandage may reduce the edema, but the most important thing is to get the patient to start moving again. Here are some red flags when a patient comes to you in the pharmacy with skin dermatitis. When should you refer the patient to the physician? First, if the symptoms reduce the quality of life. So if the symptoms are so bothersome to the patient, or if the symptoms interfere with the patient's daily life, in this case, we have to refer the patient to the physician. Also, when the patient has moderate to severe symptoms, defined as eczema that covers 30% or more of the body surface area, we can use what we call the eczema area severity index. This is a scale that's used to assess the severity of eczema. If the patient has acute and vesicular symptoms, so something that happened really suddenly, and there are vesicles, if the eczema is spreading, and if the patient has received OTC therapy but remains symptomatic after a few days of therapy, so if the patient is already taking some antihistamine or steroid therapy or something like that, OTC, and there is no improvement, the patient will have to go and see the physician. And patient with symptoms suggesting concurrent infection, so if the patient comes, for example, with fever, the patient should be referred to the physician for assessment. Goals of therapy for management of dermatitis include symptomatic relief. So we want to control the acute symptoms, and then we want to prevent the symptoms from coming back while eliminating triggers. Let's now talk about non-drug measures. And non-drug measures are, big deal in dermatitis. So there are some stuff that you should avoid, or you should inform the patient to avoid. Dryness or humidity. Not too much dryness, not too much humidity. Keep moderate humidity. Use air condition or cool humidifier. Wool and hard texture clothes, such as nylon and synthetic fibers, should be avoided. Liquid and sheets clothes softener. The sheet clothes softener is the ones that we put in the dryer to soften the clothes after washing them. We should avoid the liquid and the sheets clothes softener. Why? Because they roughen the clothes surface. They cause erection of the fine fibers, of the clothes, and this will roughen the clothes surface. We should also advise the patient to avoid sun exposure, to avoid contact sports and the sports that cause intense sweating, to avoid bleach, and to avoid powder detergent, and use liquid detergent instead. There are things that we should recommend to the patient. We should recommend loose fitting and soft clothes, cotton clothes, and we also should recommend for the patient to wash all the new clothes before using them. All the new ones should be washed. Swimming also is something that we can recommend. Even if the water is chlorinated, we can advise the patient to swim. After swimming, the patient may shower to rinse off the chlorine using mild cleanser and apply moisturizer. The patient should shower no more than once weekly, and actually preferred over um, taking a bath is preferred over taking a shower. And it's very important after taking a bath to apply emollient or body oil, and this is something very important that we'll talk about later as well. We need to trim the nails, so if the patient if the skin is itchy, the patient doesn't scratch the skin, and to wear mittens. In terms of diet restrictions, restrictions are used only when allergy to food is assumed. But it is very important to make sure that we don't apply that restriction to the extent that the patient becomes, to cause malnutrition. Diet restrictions also are not recommended in pregnancy and in breastfeeding. In infants, exclusive breastfeeding for at least 3 months, and the use of probiotic during pregnancy and breastfeeding will reduce the development of dermatitis. So exclusive breastfeeding for at least 3 months, and using probiotic during pregnancy and breastfeeding will reduce the development of dermatitis. Introducing solid food no later than 6 months. Introducing solid food no later than 6 months. will be also important. So don't wait too much before introducing solid food. And it was common that parents usually try to delay introducing eggs and peanuts to to the kids when they're young. Actually, they found that delaying the eggs and peanuts don't really help. So you can start using them early. There is no problem. Dietitian may eliminate allergen from the mother's diet, so it's not passed to the baby. So maybe it is recommended for the mother to see a dietitian to exactly explain to the mother how to avoid passing the allergens to the baby. In terms of supplements, lactobacillus probiotic and gamma-linolenic acid can help when given to infants. Now, two important things that we'll talk about now: skin soaking and wet compress. These are actually actual interventions to help with the symptoms, and these are two different things. Now, let's talk about skin soaking. That's when the patient will use water to soak a certain area of the body. This is used if the skin is dry. So the soaking is used if the skin is dry. We soak the area in tap water or normal saline with or without astringent solution or an antiseptic. If we are using astringent solution, we can use like aluminum acetate solution. It can be used for this indication. So we soak a cloth with water or the solution, the aluminum acetate solution that's diluted, and then we apply to the affected area for 15 to 20 minutes continuously. We just soak the area with the water, with or without the astringent solution. This technique is used for dry skin. There's also what we call wet compress. Wet compress, we will also use water for it, but we will use it for the skin when it's wet. So these are two different opposite techniques. Soaking is when we apply water on the affected area, cloth that's soaked in water on the affected area, and leave it for 15 to 20 minutes. This will help with the dryness. The wet compress that we'll describe now helps when the skin is wet. For example, if the patient has kind of an oozing lesion, the wet compress will help to dry up the oozing lesion. How do we use it? Okay, so we use non-irritating gauze and we wet it, just make it wet, and then we apply it to the affected area for every 1 minute, okay, for 30 minutes, and then repeat every 4 to 6 hours. So what we do is we apply it to the area for every 1 minute. So we apply, remove it for 1 minute, and then apply for 1 minute and remove it for 1 minute. We do this for 30 minutes and we repeat it every 4 to 6 hours. The whole idea here in the wet compress is when you apply a little bit of water and you remove it, you leave it for 1 minute, and then you remove the gauze. What happens is the water will evaporate, and when the water evaporates, this will cause dryness of the area. So that's why the wet compress is used in the wet skin in order to help with the dryness. In the skin soaking, which is the previous one, we apply the soft cloth to the area for 15 to 20 minutes. Why? Because we want the water to penetrate the skin and hydrate the skin. And that's why the skin soaking is used for the dry skin, while the wet compress is used for the wet skin. So in the wet compress, we get a piece of gauze, wet it with water, apply it to the skin for 1 minute, remove for 1 minute, and keep doing that. 1 minute on, 1 minute off. The idea here is during the 1 minute off, the water will evaporate and the skin will dry. And by keep doing this, the skin, if it's oozing, will dry. So we do it, reapply every 1 minute for 30 minutes, and we repeat every 4 to 6 hours. And lotion can be applied after the wet compress. There are some additional measures that we can use for contact dermatitis, such as if the patient is exposed to any irritant, we have to wash it immediately and thoroughly. The patient should avoid adhesive bandage, touching fruits and vegetables and raw meat with bare hands. And we also can recommend for the patient with contact dermatitis, here this is specific for contact dermatitis, is to remove rings when washing hands, because when we have rings and the patient has contact dermatitis, the soap can get trapped under the ring, and this actually can cause more contact dermatitis. Also, we can recommend for the patient to use unscented soap and to rinse hand thoroughly after using the soap, and to limit hand washing to only 2 to 3 times per day. So here we'll talk about the management of atopic and contact dermatitis, and there's lots of information on these two slides, but we'll try to go over them, relatively quickly. So if the patient has acute atopic or mild contact dermatitis, the lesions are usually oozing. We will use the wet compress technique to dry up the lesions. And we said what is the wet compress technique: when you apply wet gauze for 1 minute, remove it for 1 minute, apply for 1 minute, remove it for 1 minute. We do this for 30 minutes every 4 to 6 hours. If we still don't get response, then we add 0.5% hydrocortisone and we apply it thinly 3 times daily in a cream or a lotion form, and we usually use it 1 to 2 for 1 to 2 weeks to reduce the itch, the redness, and the swelling. If we're still not getting enough response, then we can add a nighttime antihistamine, first generation antihistamine. Generally speaking, when you speak about skin conditions, first generation antihistamines are the best. So um, we can add a nighttime first generation antihistamine for 1 to 2 weeks. If we continue to see no improvement, then we have to refer the patient to the physician for a steroid. By the way, the steroid that the doctor will prescribe doesn't have to be a high potency steroid. As you can see here, we used hydrocortisone. We use hydrocortisone 0.5%. When we say refer the patient to the physician, we are not necessarily expecting the physician to prescribe high potency. The physician may prescribe actually a low potency steroid, because some of the low potency steroid that are prescription drugs are really effective in this case. But anyway, the physician will decide which steroid the patient should use, and sometimes even the physician will use calcineurin inhibitors. So this is for how to manage acute atopic dermatitis or mild contact dermatitis. The second management will be for the chronic atopic or moderate to severe contact. And usually these are dry lesions. And because they are dry lesions, we will use the socking technique. We said that in the socking technique, we sock a piece of cloth and we apply it to the affected area for 15 to 20 minutes continuously. The idea is to hydrate the skin. And then we can also use bath products, and we'll talk about the bath products on the next slide. We also can use emollient. As you can see, all the target here is to soften the skin. Soaking, bath products, emollient, the idea is to soften the skin. We also can use 0.5% hydrocortisone in ointment. We all know that. If the skin is dry, we use ointment. If the skin is wet, we use cream. And that's why in the top section here, we used the cream, because the skin was wet. So we use 1%, 0.5% hydrocortisone in ointment. We use it for 1 to 2 weeks, and the ointment has occlusive effect, which helps with the hydration of the skin. If it doesn't help, we add a nighttime first generation antihistamine for 1 to 2 weeks. If it doesn't help, then we refer the patient to the physician for more potent steroid. So the management approach is very basic. Some hydrocortisone, 0.5% first, no help. Nighttime first generation antihistamine, no help. We send the patient to the physician for assessment for more potent steroid or to get some calcineurin inhibitors. We will talk now about different treatment options and some principles of management. Systemic steroids can be used for the severe cases, and then we taper them at any step. So if it's acute atopic or contact or chronic atopic or mild contact dermatitis or moderate contact dermatitis, at any phase, we have to use the non-drug measures, and it's also important to avoid the lanolin containing products. Monitoring, we have to monitor the effect in 7 days. So if it's acute, we can monitor in 7 days. If it's a chronic, it may take a little bit longer to improve, so we can give it 2 to 3 weeks. And if the effect is suboptimal, we need to ensure adherence to the non-drug measures. This is very important, and that's why we spend some time talking about the non-drug measures. The most important piece of the non-drug measures is to avoid irritants and aggravating factors. We also need to look at the treatment targets. So if the symptoms are acute, we need to see minimal adverse reactions, no itch, no progress, which means that it is not spreading, it's not blistering. We need to improve the quality of life so the patient can sleep at night and has less stress. And we want to reduce the erythema and edema by at least 50%. This is for the acute symptoms. There are also same criteria are used for the chronic symptoms. Plus, we need to see prolonged remission. So the treatment goals are the same for acute and for chronic, but for the chronic, we also would like to see prolonged remissions. If the symptoms resolve, we taper the medications to maintain remission, and as we will see, sometimes we use calcineurin inhibitor intermittently in order to maintain remission. Next point is that there is no need, and that's an important one, please remember this one. There is no need to go up the ladder of topical steroids all the way. We don't have to use low and then go to the medium and then the high and then the ultra high potency. This is not required. If moderate or to high potency steroid is not effective, you don't need to go all the way up. Don't keep pushing, and that's an important one. If the patient is taking a good medium high potency steroid, something like betamethasone valerate, that's high potency steroid, and the patient is not getting enough response, there's no way to push to an ultra high potency. No, that's enough. You can here use calcineurin inhibitors. That's better than the ultra high potency steroid. Please make sure you know this point. This is an important one. OTC clobetasone butyrate, 0.05 gram. It's a moderate potency steroid. It should not be used in children less than 12. It's available OTC, but it's not for children less than 12 years of age. And the daily dose should not exceed 15 gram per day. This is an OTC medication, and we should consult the physician before using it because some of the prescription low potency steroid may be sufficient. So if you notice, in the management, we use 0.5% hydrocortisone cream. And if it doesn't help, we add the antihistamine. If it doesn't help, we refer the patient to the physician. Someone may say, just a second, hydrocortisone is low potency, but in the pharmacy, we have an OTC medium potency steroid, which is clobetasone butyrate. Shouldn't we recommend this before we send the patient to the physician? And the answer is no. Why? Because the physician may prescribe some prescription only low potency steroid that are as effective as the clobetasone butyrate. So just refer the patient to the physician. You don't need to increase the potency just using OTC drugs. In terms of pregnancy, we use non-drug measures as the first choice. If the symptoms continue, we'll put low to medium potency steroid, and we can also use calcineurin inhibitors, and we can use systemic cyclosporin or azathioprine with close monitoring. We have to avoid methotrexate though, because we know methotrexate is teratogenic. In terms of breastfeeding, topical steroids can be used. Calcineurin inhibitors can also be used, but avoid contact with the infant, and avoid cyclosporin and methotrexate in breastfeeding. Anti-infective drugs have no role, especially the topical ones, and is more importantly, the antibacterial soaps. There is no role of antibacterial soaps in management of dermatitis. And first-generation antihistamines can be used to improve sleep and reduce itch. And as we said before, usually when you speak skin, first-generation antihistamines are the most effective antihistamines.
How can we tell if the patient who uses topical steroid or any topical medication that the patient is using an adequate amount that is not too much and not too little? This brings us to discuss something that's called the fingertip unit. So the fingertip unit is the amount of the topical steroid, or it can be the amount of the topical preparation, is squeezed out from the standard tube size. And the tube size to be standard must have 5 millimeter nozzle, like the tip of the tube must be of the size of 5 millimeter to be a standard tube. So the fingertip unit is the amount of the topical preparation that is squeezed out from a standard tube along the fingertip, from the very tip of the finger to the first joint or the first crease in the index finger. So we use the index finger to measure the fingertip unit. So the fingertip unit is equivalent to zero point 0.5 gram of the topical preparation, and this should be enough to cover 250 centimeters square, which is the both hands. So one fingertip unit um, should be enough to cover both hands, front and back, and the fingers and in between, etc. So based on this concept of the fingertip unit, this is the number of the fingertip units that are required to cover different areas of the body. So this is something that you can use when you counsel a patient on using topical preparation to identify the affected surface area, and based on this, you can decide how many um, fingertip unit the patient needs to use. Another point we want to discuss here is why some patients don't respond to topical steroids. So reasons for inadequate response to topical steroids can be something like tachyphylaxis. This happens in the case of prolonged use of the steroid. So if the patient uses the steroid for a long time, what happens is tachyphylaxis and the effect to the steroid decreases. Sometimes also it can be improper or underuse of the steroid. So for example, low potency steroids should be used 2 or 3 times daily. On the previous slide, you may have noticed that we used hydrocortisone 3 times daily. So we need to ensure that the patient is using an adequate amount of the steroid. That's why we introduce the fingertip unit. And we need to make sure that the patient is using the steroid for enough frequency. So the patient, for example, does not use it only once daily when it should be used um, twice or 3 times daily. We need first to check the reasons for inadequate response to steroids before we increase the potency. So if the patient is taking low potency steroid and the patient is not getting enough response, before we increase the potency to medium potency or to high potency, we need to make sure that the patient is using the steroid properly first.
So now we'll start talking about other topical agents that we use for eczema and atopic dermatitis. Of course, the backbone therapy includes topical steroids and calcineurin inhibitors. However, there are other agents that we still can use for these conditions. The first one we have here is the coal tar, and coal tar is used mainly for the scalp when the atopic dermatitis or the eczema involve the scalp. It is less effective than steroids, but it can be used to maintain remission in chronic cases without the need for steroids. So we may induce remission by steroids, but we can go maintenance therapy with the coal tar. The problem with the coal tar, and we'll discuss this also in other topics, that it has a bad odor. and it stains the clothes, make it less appealing to the patients. Um, Patients also may need to use bath oils, and this is an important one to remember. So bath oils reduce water loss. So what we do is after the patient has a bath, the skin gets really hydrated. And what we try to do is we try to seal this hydration in the skin. So after the patient takes a bath, we apply this bath oil. So what oils do we use? Mineral oil is used, and sometimes also we can use vegetable oil. Some patients uh, love to apply olive oil to the skin because it helps to soothe the skin. And usually, when we use a commercial preparation, these commercial preparations contain surfactant, which will increase the water miscibility. The oils, and that's something very important to please remember, oils should be used during or after the bath, not at the beginning or before. This is important to remember. So, oil should be used during or after the bath. So, again, the idea is after we take a bath or during the bath when the skin is really hydrated, we apply the oil to retain the hydration in the skin, in the stratum corneum. If we apply the oil at the beginning of the bath or before the bath, it actually will reduce the hydration because the oil will work as a water repellent and will prevent the water from getting into the skin. So that's why we need to apply it during or after the bath. In all cases, the bath oil will stay on the skin for a short period of time, and we always try to avoid scented oil and lanolin containing oils because lanolin can be a skin sensitizer. We also can use colloidal oatmeal. It has soothing anti-itch effect, but it has a minimal hydrating effect. And also they can clog the bathtub if we use the colloidal oatmeal. Soap, we advise the patient to use mild soap and to avoid excessive washing, especially when the skin is cracked, because excessive hand washing or excessive washing of the area can increase the dryness. Another important topical agents that we can use is the moisturizers, and moisturizers should be used as first line agents for the prevention and the treatment. And for sure, you will find people all the time use some sort of a moisturizer cream for their skin to prevent dryness and to prevent eczema um, and other like skin dryness. Moisturizers should be used generously multiple times daily as needed. And you will see this all the time. People will get a tube of moisturizer and apply some to the hand and rub it. And they do this maybe every hour or so. We should also use, again, unscented and lanolin-free products. These are the preferred products because the lanolin and the scented ones can cause more sensitization to the skin. We apply these moisturizers while the skin is still wet to improve water retention in the skin. Very similar to what we said about the colloidal oatmeal. Now, there are different types of moisturizers and they are classified according to their mechanism of action. So the first one we have is the emollients. Emollients reduce the water evaporation from the stratum corneum. So when we apply the emollient, they trap the water in the skin. And they usually contain glycerol and glycerol stearate. So glycerol, once we apply it, it goes in the skin and binds to the water in the skin and prevents water evaporation. Another agent that we can use, or another class of the moisturizers, is the occlusive agents. And the most basic example for occlusive agents is petrolatum. So petrolatum basically exert occlusive effect, but can cause maceration and bacterial growth. So what the petrolatum or the Vaseline will do, it will just trap the water in the skin. They don't necessarily increase the water contents in the skin, but if the skin is hydrated, petrolatum will prevent the water in the skin to evaporate. So that's the occlusive effect that petrolatum will produce. However, petrolatum has a problem because it is not cosmetically accepted. No one likes to walk, with, for example, with Vaseline on his hand. The third class of the moisturizers is what we call humectants, and also we call them hydrating agents. What they do is they draw water and hold it in the skin and control skin keratinization. And usually, humectants contain phospholipids, urea, lactic acid, lecithin, glycerin, and propylene glycol. We have also another class of agent that's called barrier repair products. So what is the barrier? Our skin naturally has fats in it. And these fats are supposed to prevent the evaporation of water from the deeper skin tissue. So our skin usually has fat. This fat is mainly coming from fatty acids and cholesterol. So the problem in patients who have eczema and atopic dermatitis is because of the excessive dryness of the skin, they lose the fatty acids and the cholesterol, which again they act as a barrier to prevent the evaporation of the water from the skin. So that's why we call these barrier repair products. So they contain ceramides that replace the natural fat, cholesterol, and fatty acids that act as a barrier to prevent the water evaporation from the deeper skin tissue. So basically, we replace the cholesterol and the free fatty acids that we lose. They are used as needed during the day, and they have a steroid and immune suppressant sparing effect. So they can help the patient to use less steroids. And if the patient is using something like calcineurin inhibitor, they can also help the patient to use less amount of the calcineurin inhibitor or for shorter duration. Finally, there are some natural medicine and some other stuff that people use. For example, some Chinese medicine and omega products, they have weak evidence. We also avoid topical antihistamines because they are strong sensitizers. We avoid bath salts and bleach, and we avoid bubble bath detergents. Other topical agents include crisaborole. Crisaborole is a phosphodiesterase type 4 inhibitor, which exerts an anti-inflammatory effect, and it's used in patients who are more than 2 years of age with mild to moderate dermatitis, and it's applied on all body areas except mucous membranes, and it's typically used twice daily. Um, Other topical agents include topical antibiotics. So gentamicin and fusidin are used for secondary bacterial infection when there is infection, not for the prevention. So they're used for the treatment of secondary bacterial infection, which is common in patients with dermatitis because of the itch. They are commonly used either alone or in combination with hydrocortisone. So, for example, we have the fusidin HC, which is fusidic acid plus hydrocortisone. Okay, so how can, in a question, how can I guess that this patient has infection? So it's important to be able to recognize the infected lesion. So infected lesions is typically oozing, has a honey crust on the top of it, or hemorrhagic crusting, which means there is bleeding. It's usually bright red and has friable tissue. Friable tissue means that tissue that easily crumble, and fever is rare. So for these patients who come with this kind of lesion, we can recommend a topical antibiotic. What about systemic antibiotics? Systemic antibiotics can be used if the infection is widespread, like large area is affected or infected, or in patients who have symptoms of systemic illness. So for example, if they have fever. What about antibacterial soaps, antiseptics, or special textiles like wipes? So these measures, the antibacterial soaps, topical antiseptics, and wipes, they are used to prevent skin infection in patients with dermatitis by lowering the bacterial count. So what they do is they reduce the number of the staph aureus on the skin, and this way they can reduce the risk of infection. And some studies show that they also can cause some improvement in dermatitis. However, they have no clear rule in the management of dermatitis, like they are not included in guidelines in managing dermatitis. Our previous discussion of treatments for dermatitis focused on topical agents. Now we'll look at other agents that we can use for the management of dermatitis. So we can use some systemic agents such as azathioprine, cyclosporin, methotrexate, or dupilumab. Dupilumab is interleukin-3 and interleukin-4 inhibitor. It's used subcutaneously, and it's usually given as initial dose and then one dose every 2 weeks. We can also use alitretinoin, which is used for severe chronic hand eczema. And typically using alitretinoin will require referral to a dermatologist. We can also use systemic steroids. However, they are not used routinely because of their adverse reactions. We also can use ultraviolet light. We mentioned earlier that ultraviolet light can aggravate dermatitis, but it also can be used medically to help controlling dermatitis. So our previous discussion focused on the management of dermatitis, what medications we can give to manage dermatitis. Now we'll talk about the prevention of flare-ups. So the first measure we will use is moisturizers, and the ongoing routine use of moisturizers at least once daily. This is the mainstay for prevention of flare-ups in dermatitis. This is the mainstay for prevention of flare-ups in dermatitis. So any patient with dermatitis, they must use moisturizer routinely, at least once daily. Other measures that we can use to prevent flare-ups include long-term intermittent topical corticosteroids or calcineurin inhibitors. Um, so what does it mean? This means that we will apply either corticosteroid or calcineurin inhibitor to areas previously affected by dermatitis to keep remission. So for example, the patient has uh, or the patient had hand dermatitis, and we want to make sure that the patient will not get hand dermatitis again. What we can do is the patient, after remission, the patient can use corticosteroids intermittently or calcineurin inhibitors intermittently to maintain remission. So what does intermittent use? So let's take steroids as an example.
Intermittent use of steroids is applying steroids 2 to 3 times weekly, and this continues for 16 to 40 weeks or longer. Tacrolimus also can be used twice weekly as intermittent therapy to prevent flare-ups. Generally speaking, the use of topical steroids for the prevention of flare-ups may be more efficacious than tacrolimus, and the doses and the use of corticosteroids and calcineurin inhibitors or tacrolimus in the prevention of flare-ups is discussed in the product monographs.